I'm joined by Dr. Sarah Burnett, a consultant radiologist, a former breast cancer sufferer. Also with us is Mr. Ahmed, a bariatric surgeon. Very good morning to you both. Sarah, if I could start with you, tell us what happened to you, because you were suffering from breast cancer, but you only found out about it by going through tests which you yourself funded. Is that right?
That's correct, yeah. My mother had breast cancer at quite a young age, so I elected quite early on to start screening. And I was screened from the age of 38, but that's not a service that's provided on the NHS. So I went and I had my scans done privately. And in 2005, when I was 43, I was diagnosed with 11 separate tumours in my right breast. The biggest of those was 13 millimetres. And if I waited until any of those was big enough to feel, then odds are I wouldn't be here now having that conversation with you. One of the problems with breast cancer is it's very much more aggressive in young women. So we're not targeting screening really to the right area.
So do you feel the NHS is failing women who are at potential risk of suffering from breast cancer?
Well, I think maybe we're pointing the resources in the wrong direction. I think part of the problem is there's a lot of political short-termism, and people are looking at, immediacy from nice guidelines or 5-year terms or even 10-year projects. What we need is a sort of generational look at the NHS, really, and the current level of funding and service provision is really unsustainable, I think, in its current form. So people really need to have a kind of almost a revolution, I think, in the way that we look at healthcare provision. What's interesting is you just highlighted that the two sort of biggest areas are actually chronic diseases. They're not even cancer and fertility and heart attacks and so forth, So an ageing and increasingly obese population, we're looking really at a time bomb.
Talking about obese populations, let's talk to Mr. Ahmed, a bariatric surgeon dealing specifically in gastric bands. There's often a lot of anger that people who are going in for this surgery who are obviously clinically obese, many argue, well, actually, there are other ways of combating that, such as going on a diet that doesn't have to cost the NHS thousands of pounds.
Yes, I think it's important to make a clear difference between treating people who are overweight and people who suffer from morbid obesity, which is not a choice, it's actually a disease. And really, I think where it comes to NHS spending, we know that treating obesity-related health problems costs the NHS £5 billion a year. This is another statistic you can add to the flowchart you were showing earlier on. And we have a highly effective treatment solution for people with morbid obesity, which is bariatric surgery.
Obviously, many people could say, well, all doctors will try and protect their own fiefdom. They won't want to see their budgets cut. But as Dr. Burnett was saying, do we need now a wholesale look at NHS funding? Because for many people, it is about lifestyle choices now, such as the story we've been talking about this morning, the idea that women of a certain age should be able to freeze their eggs on the NHS at the cost to the NHS in case they won't be able to conceive later on in life. It's not just conditions like clinical obesity, actual illnesses that go into the pot now. Other decisions are made based on other lifestyle choices, as I said.
Well, I mean, you're correct to an extent. The fact is that the NHS has a limited budget. And the way I see it is you've got to spend that money in the most effective way. Of course, all doctors and everybody wants to see every condition treated and all suffering relieved. But the fact is that there's just not enough money in the pot for that. All that I'm suggesting is that we use the money using treatments such as bariatric surgery, which are highly clinically efficient, highly cost-effective, so that money can be saved to treat those other conditions which you've mentioned also.
Let's just bring in a couple of tweets now. Cancer sufferer Ali has tweeted us. She said, if I had IVF as a result of being diagnosed with cancer. I was very lucky. Thank goodness for the NHS. I'm now due in 6 weeks. Very good luck to you. Or Siobhan Lewandon said, I think the NHS should focus on spending money on saving lives rather than making lives. Dr. Burnett, let me bring you in on that. It's a point that many people will feel strongly about, and we heard from Mr. Ahmed there that obviously all doctors want to relieve suffering. But others would argue, women in particular, who want desperately to have a child, that it's as important to them as saving a life, as an illness.
I completely agree. I mean, I'm very lucky I had 2 kids. I was offered the option at 43 of saving some eggs before my cancer treatment because my husband hasn't had children of his own. We elected not to go through that. And suffering's a subjective thing at the end of the day, isn't it? And there's a huge amount of anguish and mental health issues that can come from infertility. And the other thing is to remember is that we need people to look after us as we're getting old. So we need that next generation.
Mr. Ahmed, do you feel that culturally there's been a real shift in this country? We're talking about this pill to help people to stop drinking. It's only going to be available to those who are heavy drinkers. But perhaps a few years ago we would have just taken that as part of the natural course of life, that some people who are alcoholics have had a bit too much to drink at night. Now we're saying those people who drink more than half a bottle in an evening of wine could actually be given this pill at a cost of £3 each, costing the NHS hundreds of thousands of pounds over the course of a year.
Yes, I think there's been a change in the NHS thinking, and certainly with nice guidelines giving us very good advice on where to offer patients treatments. Certainly within the field of obesity surgery, since 1996, there's been a huge impact on obesity from what the NHS is doing. And we have very good, nice guidelines which recommend surgery because it is recognized how effective surgery is in treating this very serious condition. Don't forget, we're not really treating obesity because we want people to lose weight. We actually want to treat obesity because we want patients to become healthier. Obesity is related and associated directly with at least 12 or more serious chronic health problems which are life-threatening, and bariatric surgery can actually cause significant resolution and curing of all these health problems.
Dr. Bennett, do you feel that there's enough advice to stop some of these issues becoming problems in the first place, such as obesity, such as drinking, and also, as we've seen in this debate today, the issue of women waiting longer to have children? Is there enough awareness, enough education about all of these issues for people to make the right choices for themselves?
The advice is available, but I don't know how much people are actually aware. I think that's two very different things. With GPs being so stressed, as Beryl said earlier, and such a lack of time, it's really difficult, I think, to get the message across to people. There's probably not enough education at a basic school level in terms of future lifestyle choices, and maybe that's one of the things we should be looking at.
What's your final thought on this, Mr. Ahmed?
I think certainly public education programs are something that need to be continued with. Change for Life, for example, has been working quite well. However, we have to also accept that when it comes to overweight and obesity, when you reach the stage of clinical obesity, giving lifestyle advices doesn't work anymore, and then you have to resort to treatments which are cost-effective and clinically effective.
OK, fascinating to talk to you both, Mr. Ahmed and Dr. Bennett. Thank you for your time. Thank you.